Alright, this chapter we'll be talking about chest injuries. We'll be applying fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings for an acutely ill patient, injured patient. So we'll have to have learn the recognition of blunt versus penetrating mechanisms, open chest wounds, and impaled objects. In your pathophysiology and assessment and management of blunt versus penetrating mechanisms, hemothorax, pneumothoraxis, such as open simple injury. You also have to learn about cardiac tamponade, rib fractures, flail chest. Community cordis, traumatic aortic disruption, pulmonary contusion, blunt cardiac injury, and traumatic asphyxia. So thoracic injuries are common and severe injuries interfering with normal breathing must be treated immediately. Blood from lacerations or thoracic organs or major blood vessels collect in the chest cavity. Air can then be collected in the chest and prevent lung expansion. So some prevention strategies may be gun safety education, sports training, the use of seatbelt. Some accounts of significant number of injuries and fatalities each year. 1 in 4 trauma deaths is a direct result of thoracic injuries, and motor vehicle crashes account for a majority of patients with blunt thoracic trauma. Some AEMT. Anatomy review. Thoracic cavity extends from the lower end of the neck to the diaphragm. The mediastinum is the central region of thorax that contains the heart, great vessels, esophagus, lymphatic channels, trachea, main stem bronchia, and perivagus and peripheral nerves. So, next. Contents of the thorax are partially protected by the ribs, connected in the back to 12 thorax vertebrae, connected in the front for costal cartilage and in the sternum. So the muscles of the thorax help to protect the underlying organs, provide necessary movement for breathing. The intercostal muscles of the diaphragm are main muscles. The sternocleidomastoid mastoid muscles are accessory muscles. The trapezius, rhomboid, the latissimus dorsi muscles provide covering for the framework of the posterior thorax. The pex major surrounds the rib cages, and the trachea is in the middle of the neck. It divides into the carina to the left and right main stem bronchi. The lungs occupy the entire thorax cavity except the mediastinum. The esophagus enters the thorax via the thoracic inlet and travels through the posterior of the chest. It connects the pharynx superiorly with stomach and abdomen. The diaphragm forms the inferior border of the thoracic cavity and the superior border of the abdominal cavity. The nerves supplying the diaphragm, phrenic nerves, exit the spinal cord at the C3, C4, and C5. Physiology review. Ventilation occurs through expansion and contraction of the thoracic cage. Intercostal muscles between the ribs contract. The diaphragm contracts and descends. Inspiration is an active process and expiration is a passive process. In exhalation, intercostal muscles and the diaphragm relax and the tissues move back to their normal position. So while pulmonary respiration is occurring, blood is being delivered via pulmonary circulation to the capillaries that lie adjacent to the alveoli. Oxygenation is the delivery of O2 from the air to the blood. The ability to pump blood depends on the functional pump, the heart itself. Adequate volume of the blood to be pumped, and a lack of resistance to the pumping mechanism. Cardiac output is the volume of blood delivered to the body in 1 minute. Ventilation is the process by which CO2 is removed from the body. Chemical changes influence the rate and depth of breathing. Chemoreceptors are sensors that respond to the chemical fluctuations and are located in two major body locations. So rising levels of CO2 are mediated mainly through influence of the central chemoreceptors of the brainstem. Respiratory alkalosis results from hyperventilation. Respiratory acidosis is related to the body's inability to remove CO2. Changes in the arterial pH can modify respiration rate and depth. Ventilation changes occur in response to changes in pH detected by the peripheral chemoreceptors. In metabolic alkalosis, respiratory rate and depth decreases in an attempt to retain CO2 and lower pH levels. In open penetrating injuries, distribute forces over a smaller area. In blunt trauma, fractured ribs, sternum, are whole areas of the chest wall. Bruised lungs and heart, damaged aorta, skin and chest wall are not penetrated. Broken ribs may lacerate the intrathoracic organs, and vital organs can be torn from their attachment in the chest cavity without any break in the skin. So, in blast injuries, shock waves during primary blast compresses organs similar to blunt trauma. During the secondary phase of the blast injury, objects may be thrown and penetrate the body. Injuries to the chest has the potential to be lethal. Blood loss, pressure changes, vital organ damage, or a combination of all of these. Increased chance of hypovolemia and hypoxia. Decreased lung volume and oxygenation impair the heart's ability to pump effectively. Blood in the pericardial sac compresses the heart, eventually stopping it altogether. Myocardial valve damage can disrupt ventricular filling, and you also may have vascular disruption. Impairments in ventilatory efficiency may be rapidly fatal. Decreased air exchange and oxygenation, reduced minute volume, pneumothorax, and a decrease in tidal volume also may occur. Atelectasis and the alveolar collapse, preventing use of a portion of the lung for ventilation and oxygenation. Significantly reduces surface area available for gas exchange. In a bruised lung tissue may produce marked hypoxemia. Disruption of the respiratory tract prevents oxygen from reaching the alveoli. Alright, so signs and symptoms: pain at the site of the injury. Pain localizes at the site of the injury aggravated by bruising to the chest wall, crepitus with palpation of the chest, penetrating injury to the chest, dyspnea, hematesis, failure of the chest wall to expand normally with inspiration, rapid weak pulse, and low blood pressure. Cyanosis can also occur around the lips and the fingertips. Any change in breathing is an important sign. Fewer than 12 breaths per minute or more than 20 breaths may indicate inadequate breathing. Patients often have apnea and shallow respiration. Patients may present with bradycardia or labor respirations also. Dyspnea causes airway obstruction, damage to the chest wall, improper chest expansion, and lung compression. Hematitis is lung peritonitis or air passages have been damaged. Presence or absence of a pulse varies according to the nature of the extent of the injury. A rapid, weak pulse, and hypertension are signs of hypovolemic shock. Acid radial pulses may indicate severe hypotension. Tachycardia may indicate compensatory shock or hypoxemia. Bradycardia is generally an ominous sign. Changes in blood pressure may vary with nature and the extent of the injury. Hypertension may be the result of increased sympathetic discharge. Hypotension is a sign of hypovolemia relative to hypovolemia or late shock. Their pulse pressure indicates increased pressure on the myocardium. A loss of the peripheral pulse during inspiration suggests the pulsus paradoxus or possibly cardiac tamponade. Patients may also have hypothermia from neurogenic shock due to spinal cord injury. Diaphoresis and pallor accompany peripheral vasoconstriction, which in turn is a sign of cyanosis. Many of these signs and symptoms occur simultaneously, and signs resulting from chest injury require prompt transport and aggressive treatment. All right, your patient assessment. Ensure you're seen as safe, ensure safety for you and your partner, identify a number of patients, and do your normal stuff, such as request and consider for spinal mobilization. Form a general impression of a patient's level of consciousness. Difficulty speaking can indicate severe problems. Perform a rapid exam for obvious injuries. Your ABC, cyanosis, irregular breathing, asymmetric chest rise, and accessory muscle use in the neck while breathing, extended or engorged external jugular vein. All right, if no obvious problems, identify your lifestyle. Detect the spine and assess for spinal injuries. Examine the neck penetrating wounds and position of the trachea. You want to make sure that it's midline. Determine whether breathing is present or inadequate. Inspect for DTLS and equal expansion of the chest wall. Look for retractions. Puncture wounds and penetrating injuries suggest an open chest injury. Be alert for associated burns. Absent or decreased breath sounds on one side usually indicate significant damage to a lung. So check for your paradoxical motion. So immediately cover any open wounds with a gloved hand and apply increased suggestion to all penetrating trauma. 8 minutes to oxygen via an already breathing mask at 15 liters per minute. Identify changes in the patient's mental status. Assess support and control external breathing with direct pressure with a blood control trauma dressing. Auscultate heart sound, muffled heart tone is an important diagnostic clue. Hyperrenaissance is a tympanic drum-like sound that generally indicates the presence of the air. Hyporenaissance is a door sound that generally indicates a solid or fluid rather than air. So note the presence of the scaphoid abdomen. Jugular distension suggests increased intravenous pressure. Lack of JVD in the supine position in combination with other physical findings may suggest a hypovolemic state. To manage any immediate life-threatening condition. In your history taken, investigate the chief complaint, mechanism of injury. Inquire about dyspnea, chest pain associated symptoms, history of cardiorespiratory disease, and use of a restraint if in a NVC. Also, if there's any patient medication, the patient may be investigated associated signs and symptoms and pertinent negatives. So pertinent negatives may be non-associated shortness of breath, no rapid breathing, no absent or abnormal breath sounds, no areas of deformity or abnormal movement. Get your sample history. So basically complete basic evaluation of symptoms, allergies, medication, pertinent medical problems, respiratory, cardiovascular disease, and last oral intake. So, and always try to identify the events leading to the emergency. In your secondary assessment, look for injuries with the potential to compromise the management of the ABC. In cases of isolated injury, focus your assessment on the isolated injury, the patient's complaint, and the body regional effect. Look for ecchymosis and other evidence of trauma while assessing their skin. So repeat a full body scan, looking for decapped BTLS, obtain your vital signs, and use your monitoring device. In your reassessment, reassess vital signs, oxygenation, circulatory status, and breath sounds. Always reassess your chief complaint, reevaluate the patient every 5 minutes or less, and communicate with hospital staff early when the patient has a significant mechanism of injury to the chest. And have a complete and thorough documentation. So basically, with major chest injuries in a traumatic setting, you're going to have a lot of specialty care there also, to include cardio, thoracic, vascular guys, things. Also, your ortho people all looking at the chest. So that's why you need to notify and take these patients to a facility of appropriate care that can offer all those in the trauma setting. So, always stabilize your ABCs, primary management and concern. Always be prepared for suction, master, hypo 2. So, treat for shock and provide rapid transport if the patient has signs of hypoperfusion. Get at least one large bore IV, possibly 20 ml per kilogram. So just titrate to 80 or 90 and systolic blood pressure and call for paramedic support. So, rib fractures, infrequent injury because of the pliability of their thoracic cage occur most often in elderly patients whose bones may be very brittle. So the upper 4 ribs are well protected by clavicle and scapula, and a fracture of them is a sign of severe mechanism of injury. Morbidity and mortality increases with age, number of fractures, location of the fracture. Fracture rib may be lacerate the surface of the lung. The subcutaneous emphysemas crackling filling into the skin in the area indicates the air escaping from a lacerated lung is leaking into the subcutaneous layer of the chest wall. Ribs 4 through 9 are most often fractured. Patient usually uses an arm to splint the injury and has shallow respirations to decrease chest movement and pain. Acticulation is decreased surface area for gas exchange. Severe trauma to first and second ribs may result in rupture of the aorta, tracheobronchial tree injury, and then vascular injury. So the left lower rib may contribute to spleen injury, and the right lower rib may cause injury to the liver. So multiple rib fractures, as you can probably tell, a lot of times it's hard for these patients to take deep breaths in, so hyperventilation occurs, inadequate cough, and a lot of these patients do eventually develop pneumonia. So trying to be aware of that also. If they think it was done several days before the mechanism of injury, then they call you several days afterwards. So with a posterior fracture, the 5th and through 9th ribs are the most frequently injured. They are the flat ribs, are well protected and rarely fractured. So if you do have injury to these, it is suggestive of severe mechanism of injury. Rib fractures put the patient at risk for multiple injuries. Patients with fractured ribs may report localized tenderness, and pain on breathing. Management of rib fractures focuses on managing the ABCs and evaluate the patient for other injuries. Flared chest is a segment of the chest wall may be detached from the rest of the thoracic cage, producing a free-floating segment. It could be caused by MVC, falls of significant height, industrial accidents, assault, and significant chest trauma is required to cause a flared chest. Mortality increases with advanced age. 7 or more fractured ribs, 3 or more associated injuries, shock, head injuries. So, a lot of times with a flared chest, it does not allow for adequate oxygenation. Respiratory failure in a patient with a flared chest generally results from other associated injuries, pulmonary contusions, a pneumo or a hemo. Expose and examine the chest with DCAT BTLS. The management is to assess the need for positive pressure ventilation and administering oxygen. Use of positive pressure ventilation is required if ventilations are inadequate. So restricting chest wall movement is not recommended in these patients. Sternal fracture. A blow is significant enough to fracture the sternum, causes severe hyperflexion of the thoracic cage. Isolated sternal fractures has a mortality rate that rises with additional injuries as people age. It may result in pulmonary and myocardial contusions, flared chest, and other injuries. Expect to find localized pain and tenderness over the sternum, along with crepitus on palpation. Tachypnea is common. Maintain a good respiratory status and monitor the respiratory cardiovascular changes. Do not use overly aggressive ventilations that further exacerbate injuries. Establish IV access. Evaluate the head. Elevate the head of the long backboard to help reduce pressure on the thoracic cavity and facilitate lung expansion. Clavicle fractures, one of the most common fracture body bones in the body, occurs most often in children when they fall on their outstretched arm. Patients will report pain in the shoulder and hold the arm across the front of his or her body. It can be blended effectively with a slinger. Commotio cordis. Thoracic receives a direct blow during a critical portion of the heart's repolarization phase, leading to immediate cardiac arrest. So the patient may present with ventricular field that responds positively to early defibrillation if provided within 3 minutes. The survival rate depends on the CPR and the AED. Simple pneumo. It enters through a hole in the chest wall or surface of the lung as the patient attempts to breathe. Pressure builds in the pleural space, and most low velocity wounds self-heal. The amount of a pneumothorax that develops does vary. Suspect of a spontaneous pneumothorax in a patient who experiences a sudden, sharp chest pain and shortness of breath without specific known cause. Patient who takes a breath just before blunt trauma to the chest may experience the paper bag syndrome. If the patient is standing, an air will accumulate in the apices. If the patient is supine, air accumulates in the anterior portion of the chest. Tracheal deviation is a very late sign, is not seen in most cases. Compression of the lungs, myocardium, and great vessels causes a ventilation perfusion mismatch. Presentations and physical findings depend on the size of the pneumothorax and degree of pulmonary compromise. Patients may present with tachypnea and tachycardia. So the chest wall movement decreases as pressure increases, and hyperresonance can be detected with percussion. Immediately cover any open wounds with increasing dressing. Use positive pressure ventilation sparingly. Reassess frequently. If signs and symptoms show development of a tension pneumo, then remove the dressing. Call for paramedic backup for treatment of potential cardiac dysrhythmia and or a tension pneumothorax. An open pneumothorax, open injury chest wall that allows for communication between the pleural space and the atmosphere. Limits development of negative pleural pressure and collapses part of the lung. Hyperventilation results from increased pressure and decreased lung surface area for gas exchange. Hypoxia occurs as less oxygen is available for gas exchange. Air enters the pleural space. During inspiration phase, air may exit during the exhalation phase or may remain trapped. Direct lung injury may be present if lung peritoneum was penetrated. Then the cavity may become kinked, decreasing preload and cardiac output. Alright, air motion may be detected as patient inhales and exhales. A sucking sound may be heard on inhalation. Open or penetrating wound to the chest wall is often called a sucking chest wound. Tachycardia and tachypnea increase in relation to level of respiratory distress. Subcutaneous emphysema and decreased breath sound. Signs of hypervolemia and cardiac arrhythmias. Sucking chest wounds must be immediately treated. So place your glove hand over the injury, replace with occlusive dressing or a commercial chest seal, and secure it on 3 sides. Alright, management is famous for pneumothorax. Using occlusive dressing, record type of material used, whether 3 or 4 sides of seal, any changes in the skin color, vital signs, breath sounds, and monitor for changes. A burp dressing is the patient presents any signs of increasing stress. A tension pneumothorax increases in pressure, causes collapse of affected lung, and pushes the mediastinum into the opposite pleural cavity. Classic signs: absence of breath sounds on the affected side, underneath the chest wise, pulses, paradoxus, and tachycardia this week. Alright. Increase in pressure through the thoracic cage leads to accumulation of blood within the great vessels just outside the thoracic cage, decreasing preload. Diminished breath sounds on the affected side. Patient often reports pleuritic chest pain and dizziness. So your focus is going to be on your AEMT. Covered open wounds with occlusive dressing or non-porous dressing. If signs of developing tension are present, then lift one's corner to let air escape. Call for paramedic backup. To perform a needle chest decompression. Hemothorax. Blood accumulates in the space between the parietal and visceral pleura. Results from tears in the lung parenchyma, or parenchyma, penetrating wounds that puncture heart or major vessels. So 2 categories of chest injuries: open and closed. Closed is the force is distributed over large areas. Visceral injuries occur from deceleration, shearing forces, compression, or rupture. Mechanisms are implosion effect, overexpansion of air lungs, secondary pressure wave, inertial effect, and the spotting effect. Alveolar and capillary damage causes interstitial and intra-alveolar hemorrhage. So you will have hypoxia and CO2 retention, and it can lead to these signs and symptoms. Auscultation may reveal wheezing, bronchi rails, diminished breath sounds. So treatment pretty much supportive. Only give IV fluids if needed. Cardiac tamponade, blood, and other fluids collects in the pericardium sac. So this pretty much prevents the heart from filling during the diastolic phase. Most of the time it's seen in penetrating injuries to the heart than blunt injuries to the chest. So the pericardium attaches the great vessels at the base of the heart. So its purpose is anchoring the heart and preventing kinking of the great vessels. Fluid amounts as small as 50 ml can cause reduction in cardiac output, reduced cardiac output, hyperperfusion, and hypotension. Some physical findings are similar to those of a tension pneumothorax. So assess your ABCs, large bore IB, maintain systolic 80 to 90, and pericardial stentesis is the ultimate treatment, and it has to be done in a hospital. Myocardial contusion, basically is bruising to the heart. Vascular damage may occur. So right and left side heart failure may occur. May present with extrasternal chest pains, crackles or rails may be heard, and you're just going to provide supportive care. Acute perforation of all of these. So it causes severe blunt force to the chest, penetrating injury to the heart, and it can be a life-threatening event. It may be present with acute pulmonary edema and signs of cardiac tamponade. Rupture of the aorta. Aorta is injured at the fixed point due to the shearing force. So it most often occurs as a result of blunt trauma in MVCs and falls. High percentage of these patients have no signs of external chest trauma. So retrosternal and interscapular pain, dyspnea, dysphagia, hoarseness or stridor, ischemic pain of the extremities, upper extremity hypertension with absent or decreased strength of femoral pulses, and a systolic murmur. Usually associated with injuries to the chest, abdomen, and neck. The large blood vessels contained in the chest. So you got your superior vena cava, inferior vena cava, pulmonary arteries, 4 main pulmonary veins, aorta, and its branches. Penetrate wounds through great vessels. That may cause a massive hemo, hypovolemic shock, cardiac tamponade, and larger hematoma. A lot of times blood loss is not obvious in these situations. Transport immediately and maintain your ABC. Diaphragmatic injury may be the result of blunt. So it's basically high pressure compression to the abdomen leads to an increased intra-abdominal pressure. It may cause bowel obstruction and strangulation, restricted lungs and expansion, cardiac and respiratory compromise. So injury is separated into 3 phases: acute, latent, and obstructive. You can have herniation of abdominal contents into the thoracic cavity, or your gastrothorax is increased intrathoracic pressure, compresses the lungs. Here's your signs and symptoms of diaphragmatic injury. So dullness with your percussion, bounce sounds on the affected hemothorax, and decreased breath sound. So you basically want to elevate the head of the backbone. Esophageal injury, penetrating trauma is the most frequent cause. Basically, it causes spontaneous perforation that may occur in violent emesis, carcinoma, and anatomic distortion. So the patient typically presents with these signs and symptoms. cervical esophageal perforation, localized tenderness, subcutaneous emphysema, and resistance of the neck passive motion. Thoracic perforation of these signs and symptoms, and basically we're going to be supportive. Tracheobronchial injuries does have a high mortality rate. The site of injury is often close to a point of attachment and allows for rapid movement of air into the pleural space. So here's your signs and symptoms. Sudden severe compression injury of the chest produces a rapid increase in the thoracic pressure. Force squeezes the chest and blocks back, and blood backs up into the head and neck, causing jugular vein to engorge and capillaries to rupture. So distended neck veins, cyanosis, and swelling and cyanosis of the tongue and lips. Ocular hemorrhage may be mild. So hypertension occurs when the pressure is released. Early recognition and rapid transport. Treat symptoms. Take cervical spine precautions. Obtain IV access with 2 large 4 IVs.